morning, everyone. At the outset, I would like to thank Sarthak for the invite. My talk would focus on biceps tenodesis and how I do it. I am Dr. Sukesh. I work in Hyderabad. So the basic pathology of biceps means why does biceps have so much problem is much to do with the anatomy. See, it has two sharp curvatures, especially anteriorly and again in the coronal section. These are two friction points. Whenever the biceps rotate, whenever the humerus rotates internally, the medial pulley there is a significant friction point. That is one point where there is a possibility of tear. And also the biceps takes a right angle turn in the coronal plane. So that is again one more friction point where there is a lot of tear can happen. So all these can lead to either tendon rupture, biceps instability, biceps tendinitis, and also biceps pathology can be seen in concomitantly when there is a subscapularis tear. We all know that the upper half of the subscapularis contributes to biceps stability. So whenever there is a tear, that also causes biceps dysfunction. And also we need to address biceps tendon pathology concomitant with whenever there is a slap tear. So we have to address that as well. So these are all the areas where we have to address the biceps tendon. Now coming to that, how do you address that biceps tendon pathology? It can be either in the form of a tenotomy, wherein we cut the tendon, or in the form of a tenodesis. Obviously, tenotomy is very easy to do. It's a simple procedure. The problem is you can have this Popeye syndrome in 70% of the patients. Some patients develop cramping pain, which can persist for long term. And when done in young patients, especially who are sporting individuals, they can develop fatigue discomfort, which can be seen in as high as 38%. The other option is tenodesis. It can address all the above problems, but the only problem is if you do over-tensioning, that can cause persistent pain, and of course there is a risk of fractures. Now what does the literature say, whether a tenodesis or tenotomy? So there is a lot of literature on that. They say that there is no clinical difference. But in my practice, and I do tenodesis for young patients, and active patients I prefer to do tenodesis, and when there is a cosmesis concern, especially in lean individuals, prefer to do the tenodesis. Yeah, in elderly ladies, fatty individuals, you can get away with a tenotomy. Now if you want to do tenodesis, how to do about it? Basically, based on the anatomy, there are three zones that are divided. There is one zone that is, the first zone, zone 1 is from the articular margin to the distal margin of the subscapularis. Then you have zone 2, which is called as a no man's land, that starts from the distal margin of the subscapularis to the proximal margin of the pectoralis major. The zone 3 is the subpectoral region. So there are three ways where you can do biceps tenodesis. And you can either do in the form of an interference screw, or you can use a suture anchor for doing biceps tenodesis. Now the question comes whether the location or fixation type matters. Now if you see the inlay, it permits interference fixation, which is considered a robust form of fixation. The only problem is when you do that in the suprapectoral region, there is a risk of over-tensioning, which can cause significant pain. And also when you do that, there is a risk of stress riser and a fracture. And the only technique, it permits in situ fixation, but because it's a suture anchor, the strength of fixation is not that great. Now, biomechanical considerations have been done. There are numerous studies that have shown that there is no difference whether you do inlay or onlay. So again, and there is one clinical study assessing the fixation construct. It's a randomized study in 77 patients. They've shown that clinically the patients behave equivocally, and there is no difference in the radiographic failure. The one problem with using an interference screw, obviously if you use a larger diameter screw, is that it may end up with a torsional fracture of the humerus. So you should be very careful when you're using an interference screw. Now the next question is, does the tenodesis location matter? So like we discussed, there are two zones, zone 1, zone 2, zone 3. So zone 1 and 2, you can have the anatomical position of the fixation. The only problem is when you use an interference screw, there is a risk of over-tensioning. In zone 2, you obviously release the transverse humeral ligament, and sometimes you can address the hidden pathologies of the biceps when you're doing in zone 2. Zone 3, all the biceps pathology can be addressed, especially the muscular tendinous synovitis and all, you can address with that. But the problem is anatomic station is not addressed. Now clinically, there is only one study that I could get, that is a proper RCT that was done, assessing the suprapectoral and subpectoral tenodesis, which showed no difference. Now next comes the question, how to do the biceps tenodesis. Coming to zone 1, in the groove that you can do in the box from inside the joint, You can identify the groove, place your anchor, and then use a whatever mode of biting device that you want to take, either is a suture piercing, tissue piercing, or tissue suture passing device. So I preferably use a clever hook. I use a lasso loop to do my biceps tenodesis. So once you do the loop, you can fix it in the groove. Then coming to zone 2, the important thing, only difference between zone 2 and zone 1 is you release the transverse humeral ligament, you expose the biceps thoroughly. So any amount of residual synovitis, you release that. And then the fixation is the same. I do a 360-degree lasso technique described by Thibaut Lafosse for fixing it. So once I do that, because we know the role of SCR, biceps SCR, nowadays I cut my biceps there and I use the remaining to do biceps augmentation. Zone 3 is a subpectoral tenodesis, so it's a kind of a mini open procedure. So identify the biceps in the subpectoral region, to identify the groove, and then I use an eyelid based device from Arthrex. So I use it to do fixation in the groove. So in conclusion, you should know your technique. All the techniques are okay. There is no superiority of one technique over the other. There is no superiority of one particular fixation device. Of course, when you do zone 2 fixation, you can use the remaining biceps for augmentation. This opportunity, I will take the opportunity to invite you all for the Hyderabad shoulder course that's happening next week. The theme is very specific on the irreparable rotator cuff. We have esteemed faculty and we will be discussing only on tendon transfers in that course. Thank you.
Thank you, Dr. Sukesh.
A very good talk. I just would like to ask one question. That is, how will you decide on a subpectoral or a suprapectoral stenosis? That is, what is your clinical decision? That is, will you do it preoperatively itself, right?
To be honest, my subpectoral tenosis is only for a biceps rupture. Already the biceps that has ruptured, I've done only 2 or 3 cases. Just for the sake of the talk, I have prepared that actually. In my clinical practice, I prefer to do, nowadays I'm doing the zone 2 fixation, because if I have the rotator cuff concomitantly, I prefer to do zone 2 fixation because I am able to use the remaining biceps for augmentation. Now if I have to do an isolated biceps tenodesis, I'll just do a zone 1.
And do you do a parachute technique in which you take some of the labrum along with the biceps tenotomy so that it gets stuck in the pulley and doesn't come down?
Labrum?
Yeah, just Namdev sir, what is it?
For a tenotomy, and normally I would do that, and then you don't need to do a tenodesis, and the results have been pretty similar to a tenotomy tenodesis. You just want to prevent it from sliding down the groove.
I just wanted to know whether that is good enough as a tenodesis.
It is not tenodesis, it's a tenotomy, but it snags into the transverse ligament, and it doesn't slide down.
Actually, it works like a tenodesis.
No, it doesn't work like tenodesis. Like. No, tenodesis is fixed. This is still mobile, but there's no difference between them. The problem is, as Sukesh said, it was nice, exotic. There are too many options for us. But since the onset of biceps SCR and DAS, we've stopped doing tenotomy tenodesis. We are preserving the biceps. You never know when it will come in handy. And so we've made a big shift. We used to be biceps killers previously, left and right. Yes. But now suddenly biceps has got a newfound place. We started to worship the biceps. And it really hasn't made much difference. But I've had maybe 2-3 patients every year now coming with biceps pain because it is a pain-giving organ. I just have to inject it later on. But previously we used to do reckless tenotomy for all our rotator cuff, irrespective. It's changing now.
In an elderly individual, when you're doing tenotomy, we always do on the attachment tenotomy, so that you'll have a flower-like thing. You'll get auto-tenodesis. That is for elderly individual. Routinely for anyone who needs tenotomy, you do like that only.
Namdev sir has something. Yeah. Please take the mic, sir.
Actually, the name is the Y-shaped tenotomy, which has been described by Dr. Laurent Lafosse. So whenever you are doing the tenotomy, better to take the some part of the superior labrum in order to prevent the development of the pop deformity.
Okay, thank you, Dr. Sukesh.